It's been a long, torturous process. Anybody who says to you in the future, let's do a randomised controlled trial of 6,000 people, run a mile. It is an enormous undertaking. It is the biggest single thing that I have been involved in from a logistical point of view, from a technological point of view, from an evaluation point of view. It is enormous. It takes such a lot of time and effort and money to do this. So really, the results we get from this would lead me to, if I was in a different organisation now, the results that we get from this would lead me to say, well, why would I want to pilot this? Why would I want to try this? This has been done at scale. And that's the type of results, and okay, they're the headlines, but that's the type of results that we've had. The difference between the control and the intervention groups showed us that you can have 20% reduction difference in your emergency admissions between those in the control group who were getting normal care, those who got that care plus the telehealth intervention. 20%. Now that, if you look at the numbers that we've got back in the department and the analysts have done the work for me, that accounts for over £1 billion. If you can scale that up to about 3 million people, it's about £1 billion of savings. Forget the savings, forget the fact that this might actually make a difference in terms of the finances. Look at that figure on mortality. 45% difference, the reduction, 45% reduction in mortality. So we've been very keen to do this in partnership. And the reason we want to do this in partnership is because I went to a number of meetings over the summer last year and sat down with various different people from various different parts of industry and said, individually, these companies, each of you have been trying to deliver telehealth and not really been very successful, let's be honest. Even though, we are still ahead of the game in Europe. We are leading the way in Europe and one of the leaders in the world. We've not been very successful. So, NHS, you have been trying to do this and you've not been very successful. Government, you've been talking about it for a number of years. We've been wanting it. We've not been very successful. So why? And it was all those barriers being in the way. So why don't we all, instead of trying to come at this individually, come at this together and think of a way of trying to build a solution. And that's what 3 Million Lives was about. And essentially it's about saying, look, we know from whole system demonstrator results that you can do this. You can actually find a way of delivering services differently to people, the way that they want them, which reduces the use of dependency on hospitals, which can provide a better opportunity in terms of mortality rates, can give people the chance to live the life that they want, to support self-care. But we also know that to do that, we need to completely redesign the service, going right back to what I said at the beginning of that triangle, thinking about the types of people, the types of services that they want, and how we design the care around that. Then you can start putting the technology into support. But going back to the barriers, we need to think about economies of scale. So how many, how much? And I asked my economists in the department, I said, look, of that 15 or 16 million people in England that we know of who have a long-term condition, how many could benefit from the types of interventions that we used in the whole system demonstrator program? And they went away into the darkened rooms and whatever they do as economists, and they came out and they said, look, we've done all the numbers, we've looked at this, we think there's at least 3 million people who could benefit from this. And that's really, if you think about the way a whole system demonstrator was set up, that's really the top part of that triangle and getting down into the second part. So there's a lot more people with different types of interventions who might actually benefit from different types of telehealth and telecare. But so we say, okay, so there's about 3 million. We know there's about 5,000, maybe 6,000 pieces of telehealth equipment being sold in this country. Whether they're being used is another thing, but we know there's about 5,000 or 6,000. And about 1.5 million pieces of telecare. But each of those might be, not individual people, particularly in telecare, because often people with the need of telecare use 2, 3, 4, or 5 different pieces of equipment. So we know there's huge numbers of people whose lives could be affected by this, about 3 million. So it seemed to me that it seemed obvious. Why don't we pool our resources to try and do this for 3 million people. So 3 million lives is about trying to improve the lives of those people within about 5 years, using telehealth and telecare in a completely different service. So redesigning the service to encompass all of those things that we talked about in long-term conditions care for us for a long time. It's not about setting targets. We're not going to say, I tell you what, down here in Surrey you have 250,000 and we'll come along each few weeks and tick the box here how many you've got. It's not about that. It is genuinely about saying how together can we bring this to the masses, to 3 million people, the people who need it. And that means industry doing something which they've not done previously. And that's coming together and saying, I tell you what, we will change our price point. Not just one company, but all of our companies. We will change that price point to make it effective. Actually, it's going beyond that. And this is where some of the discussions we've been having with industry have got. It's going beyond that price point and getting into a different model of care. And it isn't about selling the boxes to you. It's not about saying, I'm going to give them a 250, 350 pounds, which is about how much they go for in America. It's actually saying, well, why don't we share the risk? And the risk is often seen as, well, if I sell them to you, I walk away. You've got all the risk because you spent all this money, you're not getting anything out of it. But if I give it to you for nothing, you've got all of the benefits, NHS, and I've got all the risk because I'm not getting any income. My company would fall. So share that risk. Something about a different business offering. And it's about a revenue model. It's about saying, let's look at this in a different way. Is there a way of using it in the same way as possibly we go for things like iPhones, or we did it for colour televisions when we first set up the colour television market. We go for rentals and revenue markets to actually generate the numbers and also give an income to the companies. So that's the business model, that's the business offering, and there's a whole work strand within 3 Million Lives led by industry, which is about designing all of that and doing all of those things to make it a more simple offering for the NHS and for local authorities. But we need to be able to respond to that. We need to be able to say, well, that's great. Now, what are we going to do about changing our business, our models of care to respond to that and deliver care in a different way? So there's a whole health strand being designed and put together as part of 3 Million Lives, which is about what do we do to respond to that in a way which is going to be able to help us take some of that capacity out of one sector and build it into another. Use this resource and the people we've got in a way which actually supports the type of care we want. That's massive. That's a huge undertaking, and that's part of the challenge that Sir David Nicholson talks about when he talks about the biggest change in human history. You can see it from space and all that sort of thing when it comes to the redesign of the health service. So that's all part of what we're trying to do. But I would go one step even further on that and start saying, think about the care packages. If, as a PCT or as a clinical commissioning group, a company comes to you and tries to come up with whatever the deal is, selling it, revenue, lease, whatever, comes to you and says, look, this is how we should do this. A CCG, a PCT could get into all sorts of contractual relationships, but actually, who's delivering the care? Who's actually going to be delivering that service to people? It's the community health provider, it's the NHS Foundation Trust, it's the whoever's doing it. So it makes more sense for the contractual relationship to be between the company and the health provider. And they can then provide a package of care which is then offered at a reasonable rate to the commissioner. Because the problems that we've seen by some of the places around the country who've already tried doing telehealth and skilling, a lot of the problems have been because the commissioner have put their head above the parapet and we will do this. And I think, hats off for them for trying it. But what's happening is they then get it, they come into a deal, they have however many it is, they've got them in a cupboard, metaphorically speaking. Then they go along to the health provider who they've also got contracts with to do their healthcare. And they say, right, we'd like you to integrate this, please. It's not part of the design of their service, so some of them are reluctant and it takes more time, it finds it a bit more difficult. So it's something about getting a package of care which is then designed with the technology in mind, which can then be offered or tendered for by the Commissioner. So I think it's all of those things. We need to think all of those things through. Not just this works, let's buy it. We need to think the whole piece through. And that's what the 3 Million Lives programme is all about in terms of what we're leading on. And I've got, over the next couple of weeks, some very important discussions with leaders from some of the Royal Colleges, for example, about, well, how would they work with us to support the messaging and the changes that might be needed amongst some of the clinical professionals. And also with the voluntary and charitable sectors in terms of, well, what can they do? So there's all sorts of things that need to be done if we're going to get this to work. And it isn't just about, there's the evidence, let's get the price down and let's do something. It's about redesigning the service. And all I would say is that if anybody really wants to get into this, this is the time, this is the opportunity. It isn't going to miraculously happen. It's people like yourselves who are going to help us do this. Without doing it and without giving it a try, it will just fail, simply. And we will continue to have a system of people with long-term conditions having their care in a place that they don't really want at a cost that we can't afford, which will end up with us having a system which is costing us more than we possibly can afford going forward. But also I'd go back to that 45% reduction in mortality figure. Morally, can we really avoid this? Can we really sit here and say, tell you what, somebody else can do this? I don't think we can. We have to look at how we can do things differently. So all of this together is about service change, not just about the technology, and it's about improving the experience of the individual. Because currently that's, in my head, what they're getting. And that's not good enough. It is simply not acceptable to have a situation where patients and public alike are being unable to get the care that they need at a time when they want it, in a place where they should be able to receive it. Up until fairly recently, we haven't been able to do it because the technology hasn't been there, but the last 10 or 15 years it has been. The next 10 or 15 years, we've got to make it work. We've got to really find a way of getting this to the people. And that's why over the next 5 years, we really want to do all those things I talked about. Design a new business model so we get different offerings, a response to that in terms of how we design and deliver care in a different way, which is about understanding the needs of the patient, about looking at workforce issues. What is it that we need to be doing with our workforce colleagues to help them understand how they change? Do they need to change? Where they need to change? And what can we do to support that? So we no longer have this type of experience. And also build in the incentives so that people are getting the, I was going to say the saving, but it's essentially, if you are the one who's innovating, you need to be the one who's benefiting. It's a simple human trait. Otherwise, why would you do it? And I'll leave you with one last thought. If we in the NHS and government don't do this, I'm prepared to put money on the table and bet with anybody in this room that in 15 or 20 years' time, it will have been done elsewhere. It will have been done in more or less the same way as we've been doing it, we've been talking about it, and they'll be selling it back to us at a high cost. So why should we give up our innovation lead? Why shouldn't we benefit from that for the people of this country and also for us to then sell it to others? So thank you very much.